Hey everyone, welcome back to The Explainer. Today, we're diving straight into something absolutely fascinating, decoding borderline pathology. And we're going way beyond those basic textbook definitions. We're going to unpack the exact anatomy of this incredibly complex condition, tracing it all the way from its underlying neurobiological hardware right up to its deep structural diagnostic framework. It is just an awesome integration of biology and psychology. And I promise, by the end of this, you'll have a crystal clear understanding of what's really going on. All right, here's our roadmap for today. We'll hit the clinical picture first, then explore the biology of aggression, look at immature defenses, see how that builds into a borderline organization, and wrap up with targeted management. Let's get into it.
Starting right off with Section 1, the clinical picture. Let's take a look at what clinicians are actually seeing on the ward.
So I want you to think about this core clinical question. Have you ever wondered why a patient might think you're the absolute best clinician in the world on Monday, but by Tuesday, they're completely vilifying you? It's such a jarring shift, right? What is actually driving that extreme polarity? Keep this question in the back of your mind because it's going to anchor everything we talk about today. Let's look at a classic vignette to really ground this. Picture a young woman on the ward. Now, just as a quick aside, community prevalence of this is actually pretty equal between genders, but we do see this specific presentation a lot in inpatient settings. So she loves the team on Monday, right? Praises everyone. But by Tuesday, she condemns the exact same team as fundamentally cruel. Underneath it all, she's struggling with this profound sense of identity diffusion. She can't even articulate who she is, and she ends up self-harming after perceiving an intense threat of abandonment. We are going to solve the mystery of this exact presentation today. Moving right along to Section 2, let's look under the hood at the biology of aggression. What is the actual hardware driving this patient's reactive anger and self-harm? This right here is an absolutely crucial differential diagnosis. We have to separate the kind of aggression we see in borderline presentations from other pathologies. On the left, you've got reactive aggression. This is hot, impulsive, totally driven by frustration, and highly sensitized by trauma. This hot aggression correlates perfectly with the DSM-5 criteria for impulsivity in borderline personality disorder. Now flip over to the right side. Instrumental aggression. This is cold, deliberate, planned, and goal-directed. This is the stuff that characterizes antisocial personality disorder, or psychopathy. Knowing that our vignette patient is dealing with hot, reactive aggression completely changes how we approach her care.
So let's look at the actual brain circuitry of this reactive aggression. It operates on this distinct, interconnected triad. First up, we've got low central serotonin function, specifically reduced CSF5-HIIA. Serotonin is normally your brain's brake pedal, so when it's low, impulsive aggressive actions just get disinhibited. Second, you have an overreactive amygdala sounding a massive, threat-driven alarm. And third, this is all happening because there's reduced prefrontal control. The ventromedial and orbital frontal cortex are basically failing to step in and restrain that amygdala. You lose that top-down control, and boom, the bottom-up threat response just takes over completely. All right, so that's the hardware. Let's hit Section 3, Immature Defenses, to understand the unconscious psychological drivers of our vignette.
To really get this, we lean heavily on George Vaillant's hierarchy of defense mechanisms. Now look, defenses aren't a bad thing. We all use them. They're just automatic, unconscious processes our ego uses to manage anxiety. But Vaillant made a brilliant observation. The habitual, predominant level a person defaults to under stress is what actually tells you their diagnostic story. He ranked these from psychotic down to immature, neurotic, and mature. Borderline patients, like the one in our vignette, habitually rely on that immature tier to handle their internal distress.
And the absolute classic immature defense we see here is splitting. Think of it as keeping contradictory ideas about yourself and others totally rigidly separated, just because they are way too overwhelming to integrate. It's a completely all good or all bad view of the world. And honestly, this totally explains our vignette. This is exactly why our patient thought the team was basically perfect on Monday and irredeemably cruel on Tuesday. She's literally just deploying splitting to manage her own overwhelming anxiety.
Then there's projective identification, and this one is just wild. Basically, the patient projects an unacceptable part of themselves onto someone else, like you, they're a clinician, and then they unconsciously act so provocatively that they literally pressure you into feeling it. So a patient might poke and prod until they provoke you into feeling genuine anger. And once you get mad, it basically confirms their internal projection. It is a huge driver of countertransference on the ward, which is why recognizing it is absolutely key for keeping your own cool.
Okay, so how do all these biological and defensive pieces actually fit together? Let's look at Section 4, Borderline Organization. To really grasp this, we have to look at Otto Kernberg's object relations model. Kernberg did this amazing job of integrating psychoanalytic drive theory with object relations to map out severe pathology. In his framework, your personality isn't just a jumble of thoughts. It's built of these structural units, a representation of the self, a representation of the other, or the object, and the intense emotion, the affect, linking them together. And these are usually laid down during highly charged early emotional states, often involving an excess of constitutional aggression.
Now, take a look at how Kernberg maps this out. This is brilliant because it perfectly isolates borderline organization right there in the middle row. He defines personality organization by 3 variables: identity, defenses, and reality testing. Someone with a neurotic organization has an integrated identity. Someone with a psychotic organization has actually lost reality testing. But borderline organization sits right between them. They suffer from identity diffusion. They rely heavily on those splitting-based defenses we just talked about, and this is so important, their reality testing is grossly intact. Fragile under stress, for sure, but intact. It's a highly specific structural diagnosis.
So, what do we actually do with all this deep structural knowledge? That brings us to Section 5, Targeted Management. Because we know the exact deficits now, we can use highly targeted, evidence-based treatments. For the psychological structure, we've got transference-focused psychotherapy, or TFP, which actually comes straight out of Kernberg's model. It uses the therapeutic relationship in the here and now to actively integrate those split all good and all bad representations. Then you've got mentalization-based treatment, MBT, from Bateman and Fonagy. That's all about stabilizing the patient's fragile reality testing by helping them read mental states better, especially during attachment stress. And biologically speaking, we can use pharmacotherapy like SSRIs or mood stabilizers to specifically hit that low serotonin reactive aggression. We are literally matching the treatment directly to the anatomy of the pathology.
But I want to emphasize a really crucial clinical nuance from the source material here. We have to remember the humanity behind all this. We never just hand a patient a diagnostic label like it's just a bare word. If we do that, we risk amplifying self-stigma and triggering what's called the why-try effect, where the patient just internalizes the prejudice of the label and gives up. We use this structural framework to guide our treatment, not to trap the patient in a box with stigma.
Which leaves us with this final thought. If a patient's seemingly chaotic, frustrating behavior on the ward is actually a highly structured, biologically rooted defense against the primal threat of abandonment, how is that going to change your very next clinical encounter with them? Hopefully, armed with this structural map, it'll turn that frustration into really deep, targeted clinical insight. Thanks so much for joining me for this explainer, and keep exploring.